Okay, hi, good afternoon, everyone. I'm Dr. Thomas, and I'm going to be speaking to you guys about upper GI bleed, the pre-endoscopy management, and timing for endoscopy. I'm quite sure every one of you are quite familiar with upper GI bleed and its management. I'm just going to touch upon some common causes, a scoring system we have, and also upper GI bleed, special groups of people, i.e. those with comorbidities. So upper GI bleed is one of the most common medical emergencies and remain an important cause of hospital admission, not only in Malaysia, but all over the world. It's an important cause of morbidity and mortality. Traditionally, in maybe 10 years ago, upper GI bleed was solely managed by surgeons. However, over the last decade, UGIB have been jointly managed by both gastroenterologists and also surgeons. So as in with any patient, history taking, physical examination, and resuscitation needs to proceed simultaneously. Eventually, I think endoscopy has become the cornerstone of diagnosis, risk stratification, and treatment of peptic ulcer disease, which is one of the most common causes of upper GI bleeds. So basically, upper GI bleed presents with hematemesis, which is vomiting of blood or coffee ground-like material. Suggests bleeding proximal to the ligament of Treitz. Now, ligament of Treitz is a fold of peritoneum which suspends the duodenal jejunal flexure. So they present with hematemesis, and they also present with melena, which is black tarry stools. 90% of them originate proximal to the ligament of Treitz. So symptoms which suggest severe bleeding is orthostatic dizziness, confusion, angina, severe palpitations as a result of anemia, and also cold or clammy extremities, which means patient could be quite hemodynamically unstable or probably in shock. So factors that are predictive of bleeding coming from an upper GI source. So of course, history of melena, melenic stools during examination, blood or coffee ground detected during nasogastric lavage, ratio of blood urea to serum creatinine of greater than 30. Please remember that blood clots in stools, it's less likely an upper GI source, okay? However, hematochezia or red or maroon blood in stools, usually they occur with lower GI bleed. However, they can occur with upper GI bleed associated with orthostatic hypotension. Okay, so always keep that in mind. So some common causes of upper GI bleeds. One of the common causes, more than 50%, is gastric ulcers or duodenal ulcers. Other causes, 10 to 20% are varices, which I won't touch so much today. I'll talk about non-variceal causes of upper GI bleed. Mallory-Weiss syndrome, which is a tear in the esophagus due to vomiting or retching or forceful vomiting. Other less common causes, reflux esophagitis, 2 to 5%. Hemorrhagic gastropathy and erosions, 15 to 20%. And of course, gastric tumors or carcinoma, which is less common. Other uncommon causes, of course, hereditary telangiectasia, pseudoxanthoma elasticum, patients with blood dyscrasias, and also portal gastropathy. So, as with anything, history taking is pretty important. Specific causes of upper GI bleeding may be suggested by the patient's symptoms, so always talk to the patient. Patients presenting with upper abdominal pain, most likely is a peptic ulcer disease. Patients with odynophagia or dysphagia, most likely is an esophageal ulcer. Mallory-Weiss tear because of emesis, retching, or coughing prior to hematemesis. Variceal hemorrhage or portal hypertensive gastropathy. Patient presenting with jaundice, abdominal distension. They could have other signs of chronic liver disease such as spider nevi, gynecomastia, loss of secondary sexual characteristics, loss of axillary hair, and malignancy, dysphagia, early satiety, loss of weight, and cachexia. Constitutional symptoms, basically. So past medical history, very important. So always ask the patient regarding past history of upper GI bleeding. So if there is previous history of upper GI bleeding, up to 60% actually comes from the same lesion. And comorbidities is very important, which will influence our management. So patients with coronary artery disease or pulmonary disease, you have to remember that they are more susceptible to the effects of anemia. So in this kind of patients, you want to maintain the hemoglobin at a higher level. Also in patients with renal disease or also congestive cardiac failure, they are predisposed to, of course, volume overload in the setting of vigorous fluid resuscitation. So in such patients, you may want to have a little invasive monitoring, maybe put in a central venous line, a CBD, monitor the input-output chart. Of course, patients with peptic ulcer disease with history of H. pylori infections, NSAID use, ask for antithrombotic use and smoking, and also malignancy, history of smoking, alcohol use, or H. pylori infection. Of course, remember those with low platelet count or liver dysfunction or coagulopathies, bleeding is more difficult to control. So this kind of patients, you may want to transfuse them with platelets or FFP or prothrombin complex concentrates prior to endoscopy. And of course, patients with dementia or encephalopathic patients, they are more prone to aspirating GI contents into their lungs. So of course, decision whether you electively intubate them to protect their airways prior to endoscopy. Medication history, this is pretty important for us. So aspirin, common cause of peptic ulcer disease, along with other non-steroidals, including COX-2 inhibitors, clopidogrel and other anticoagulants, which of course can promote bleeding. Of course, also SSRIs and calcium channel blockers have been associated with GI bleeding. And of course, at the back of your head, remember things like bismuth, charcoal, licorice, and iron, which can, of course, turn your stool black, so it may not be a upper GI bleed. Okay, physical examination. So always important is hemodynamic stability. Make sure you examine the patient, check their blood pressure, check their pulse, look for cold, clammy extremities, and you got to resuscitate them with adequate fluids. Now, signs of hypovolemia. If they have mild to moderate hypovolemia, they have less than 15 blood volume loss, they will have resting tachycardia. Okay, so it's important to check their pulse. Blood volume loss of more than 50%, less than 40%, they get orthostatic hypotension. So systolic blood pressure drops by more than 20 millimeters mercury, and heart rate increases by more than 20 beats per minute when you put them from lying to standing position. And of course, if they have more than 40% blood loss, they will have supine hypotension. Okay, have a high degree of suspicion when you have patients complaining of abdominal pain. Is it an acute abdomen? Especially if it's associated with tenderness or involuntary guarding, really raises the concern of a perforation. So, of course, you got to evaluate them further to exclude the perforation, i.e., you do what you call an erect chest X-ray to look for air under the diaphragm prior to endoscopy. So, laboratory data. Basically, we will send the common investigations, full blood count, renal profile, liver function test, coagulation studies. So full blood count, basically, always remember, in a patient with an acute upper GI bleed, the hemoglobin might not drop in the first day. It usually drops after 24 hours, because in the first 24 hours or first couple of hours, patient is losing actually whole blood. Okay, and after 24 hours, the blood gets diluted by extravascular fluid into the vascular space and also our fluid that we are administrating. Also remember, excessive volume administration can lead to a falsely low hemoglobin. So these kind of patients, you want to monitor their full blood count 2 to 8 hourly, depends on severity. And also remember, in acute bleeding, you'll get normocytic, normochromic anemia. as compared to someone who is chronically bleeding. They will present with microscopic hypochromic anemia. A renal profile, so elevated blood urea to creatinine ratio. Okay, as the patient bleeds, blood will get reabsorbed in the small bowel, and also they have decreased renal perfusion. Hence, patients with upper GI bleed typically have an elevated urea to creatinine ratio. So the higher the ratio, the more likely it is an upper GI bleed. A liver function test, of course, looking for bilirubin, looking for elevated transaminases. A coagulation profile, of course, looking at their INR values. Do an ECG cardiac enzyme if you think patients are at high risk of getting an ischemic event or myocardial infarction. So pre-endoscopic management for non-variceal upper GI bleed. These are non-variceals, not due to varices. So immediate assessment of hemodynamic status in patient who presents with acute upper GI bleed with prompt intravascular volume replacement, initially using crystalloid fluids if hemodynamic instability exists. So if patient is hypotensive, cold, clammy, periphery, tachycardic, please resuscitate them with adequate fluids, preferably crystalloids to begin with. Okay, coming to transfusion. Now, most of our patients come with comorbid. So in a patient with no history of cardiovascular disease, we will only transfuse them if the hemoglobin is less than 7. Okay, and in a patient with, of course, a target HB for this kind of patients is about 7 to 9. But in a patient with acute or chronic cardiovascular disease, the threshold is you would transfuse them even if their HB is below 8, and a post-transfusion target hemoglobin of more than 10 is desired. Okay, just remember just a bit about variceal bleeds, that you can't over-transfuse them because it can worsen the bleed, and avoid transfusing patients with a variceal bleed to achieve a hemoglobin of 10 or more. Okay. Okay. So this is a scoring system which we have, a Glasgow-Blatchford scoring, a bleeding score. So basically, it's a screening tool to assess likelihood that a person with acute upper GI bleed will need to have medical intervention such as blood transfusion or endoscopic intervention. Okay, it's also used to identify people who do not need to be admitted to the hospital after an upper GI bleed. So it's a pre-endoscopic risk stratification. So basically, if the score is 1 or less, they are very low risk of rebleeding, mortality within 30 days, or needing hospital-based intervention. And some of them can be safely managed as an outpatient with outpatient endoscopy. Okay, so the couple of values here, the blood urea, hemoglobin, both in men and women, systolic blood pressure, and other markers. Okay, so a patient with a score of 0 has minimal risk of needing an intervention, likely transfusion, endoscopy, or surgery. So this patient can be considered for early discharge and outpatient management. Okay, so not all patients need to be admitted and managed as an inpatient. However, any score higher than 0 has a high risk for needing a medical intervention in terms of transfusion, endoscopy, or surgery. And if the score is more than 6, they were associated with greater than 50% risk of needing an intervention. So probably this is the way you can sell it to the surgeons. Since there are only surgeons in Sungai Buloh Hospital, this is the way you can sell it to them to get a scope early, or rather not to get a scope. You can treat them as an outpatient. So pre-endoscopic management of patients with anti-thrombotic agents, antiplatelets and anticoagulants. So this, most of our patients, so acute upper GI bleed in patients taking antiplatelets, aspirin or Plavix, the common ones. So when you do a scope, it demonstrates a non-variceal source of hemorrhage, i.e. a peptic ulcer disease. So you need to look whether the patient is on antiplatelets for primary prophylaxis or secondary prophylaxis. So if they are on for primary prophylaxis, so you would continue to withhold the low-dose aspirin, and you'll only resume the low-dose aspirin after careful re-evaluation of its clinical indication. Okay? So in primary prophylaxis, withhold aspirin and only resume after careful evaluation of its clinical indication. Okay, however, for a patient who's on aspirin or Plavix for secondary prophylaxis, known cardiovascular disease. So you would want to, just say he's on a single antiplatelet, only aspirin, you would continue the low dose aspirin without interruption. And if aspirin has been stopped, you would want to resume it within 3 to 5 days. And second look endoscopy should be at the discretion of endoscopist prior to restarting aspirin. And if it's a patient on dual antiplatelet therapy, you would continue the low dose aspirin without interruption. And the second antiplatelet agent should be restarted as soon as possible, preferably within 5 days. Okay, and when in doubt, always call your cardiologist and speak to them, tell them the finding of the scope, and to find out the appropriate time of restarting the second antiplatelet agent. And again, second look endoscopy is on the discretion of the endoscopist. Another important group of patients are patients taking vitamin K antagonist or direct oral anticoagulants, NOACs basically. Patients taking warfarin or those taking dabigatran or apixaban. So in these patients, you want to withhold anticoagulant at time of patient presentation. So in patients taking warfarin and with hemodynamic instability, so you can give them low-dose vitamin K supplemented with intravenous prothrombin complex concentrate or FFP if PCC is not available. So this is the way you manage them. In patients taking NOACs with severe ongoing bleeding, of course, we should ideally use the reversal agent. In Sungai Buloh Hospital, if I'm not mistaken, we have the reversal agent for dabigatran, but not for Rivarox and apixaban. Okay, so in this kind of patients without the reversal, so you should IV PCC should be considered. And upper GI endoscopy, and if required, endoscopic hemostasis should not be delayed. So if your OGDS shows non-variceal source of hemorrhage, anticoagulation should be resumed as soon as bleeding has been controlled. So preferably within or soon after 7 days of bleeding, based on the thromboembolic risk. Always use your scores that we know, CHEST-VAD score and your HES-BLED score, which will help you to guide your clinical decision making. Always remember, NOACs have a faster a rapid onset. So of course, adequate timing to restart it is important. PPIs. So PPIs, when it comes to giving PPIs for those who are hemodynamically unstable compared to hemodynamically stable is the same. So basically, high-dose proton pump inhibitor therapy is considered in patients presenting with acute upper GI hemorrhage to downstage the endoscopic stigmata and thereby reduce the need for endoscopic therapy. However, this should not delay an early endoscopy. Okay, so we always give 80 milligrams per hour followed by, 80 milligrams bolus followed by 8 milligrams per hour. So some guidelines for you guys from the European Society of Gastrointestinal Endoscopy. So, some guidelines, it says that they don't recommend the use of somatostatin or its analog octreotide in patients with non-variceal upper GI bleed. Okay, so basically octreotide or somatostatin analogs, what they do is it reduces portal and variceal pressure, as well as it also reduces splanchnic and portal systemic collateral blood flow. Hence, it helps to reduce variceal bleed. But when they used it in non-variceal bleed, i.e. peptic ulcer disease, there was no proven benefit. Okay. Also, the ESGE doesn't recommend use of NG tube or orogastric tube in patients with acute GI hemorrhage. Okay. The worry is while you're putting it in, you may rupture one of the varices. They also don't recommend routine endotracheal intubation for airway protection prior to upper endoscopy in patients with acute upper GI bleed. Okay, except in special cases like they say ongoing active hematemesis, patients who are demented, agitated, and cephalopathic, you may want to intubate them. Okay, pre-endoscopy administration of intravenous erythromycin in selected patients has shown to reduce the need for a second look endoscopy. It also improves endoscopic vascularization. It decreases the number of blood units needs to be transfused, and also it does reduce hospital stay. So erythromycin is a good drug, pre-endoscopy. So like I said, patients with coronary artery disease or pulmonary disease, you want to maintain their hemoglobin at a higher level. So we want to make sure in a patient with known coronary artery disease, the HB is below 8, you want to transfuse them to achieve a HB of about 10. Renal disease, heart failure, like I said earlier, predisposes to volume overload, needing more invasive monitoring during resuscitation. Yeah, patients with a low platelet count, coagulopathy, thrombocytopenia, significant hepatic dysfunction, is more difficult to control bleeding, and of course, demented and hepatic encephalopathy patients, higher risk of aspiration of GI contents into the lung. So if your platelet count is less than 50,000, you may want to transfuse platelets. If your INR is more than 2, you should give FFP or prothrombin complex concentrates. Patients who's on warfarin, you want to give low dose vitamin K and plus PCC or FFP. Patients who are uremic. So uremia causes platelet dysfunction due to both decreased platelet aggregation and impaired platelet adhesiveness. So correction of platelet dysfunction is desirable in patients who are actively bleeding or who are about to undergo surgical procedure. So of course, we choose to dialyze them. So dialysis is often recommended in uremic patients with active bleeding and who are in the need of invasive procedures. So a little bit about timing of upper GI endoscopy. So basically we have 3 types. One is urgent, which is less than 12 hours, early less than 24 hours, and delayed more than 24 hours. So the ESG guidelines say that following hemodynamic resuscitation, early or less than 24 hours upper GI endoscopy should be performed. So they do not recommend scopes as an urgent procedure below 12 hours because as compared to an early endoscope, because patient outcomes are not improved. So, and they don't recommend anything below 6 hours as this may be associated with worse patient outcomes. And also they say ESGE recommends that the use of antiplatelet agents, anticoagulants, or predetermined INR cutoff levels should not be used to define or guide the timing of upper GI endoscopy in patients with acute UGIH. Okay. So basically, patients with upper GI bleeding who are at risk of further bleeding or death, endoscopy performed within 6 hours of gastroenterological consultation was not associated with a lower 30-day mortality than endoscopy performed between 6 and 24 hours consultation. So they do not recommend it's done earlier. So at about 24 hours is perfect. So some literature review from the New England Journal. This also says, although, does urgent endoscopy improve outcomes of upper GI bleeding in high-risk patients? So I just picked a snip of it. Although urgent endoscopy resulted in more endoscopic interventions performed, it did not result in lower rebleeding or death rates compared with endoscopy performed within 24 hours of GI consultation. So in most patients with UGIT, physicians should initially concentrate on providing early resuscitation, supportive measures, and treatment of coexisting active medical conditions, and then perform endoscopy within 24 hours. So there's no rush for endoscopy. We should always resuscitate the patient adequately, treat their active medical conditions, support them, and then we post them for a scope. So another article also from the New England Journal, acute upper GI bleeding, good night, sleep tight, endoscopy can wait till the morning. Proceeding to immediate endoscopy raises potential safety concerns, including inadequate resuscitation and the risk of out-of-hours endoscopy when fewer resources and support are available. So patients who respond to hemodynamic resuscitation, urgent endoscopy within 6 hours of presentation does not offer significant benefits over early endoscopy within 24 hours. Okay, and a lot of them with acute UGIBs may actually resolve with supportive and pharmacological therapies without requiring endoscopy. So don't push for that. So optimal timing for endoscopy in patients with acute upper GI bleed. For patients who do not require admission, undertaking endoscopy within 24 hours seems appropriate. Patients presenting with UGIB and hemodynamic instability and or suspected variceal bleeding require prompt resuscitation prior to endoscopy. So they keep harping on prompt resuscitation. Relevant comorbidities should be addressed. The higher risk group may need urgent endoscopy within 6 to 12 hours, although some studies have suggested using the Glasgow-Blackford score of more than 12 to identify patients who will benefit from urgent endoscopy. However, this has not been confirmed. So individuals who receive endoscopy within 6 hours of presentations were more likely to receive intervention and have a higher transfusion requirement, but also likely to require repeat endoscopies and have inadequate visualization of bleeding sources than those with endoscopies at more than 24 hours from presentation. And when they compared length of hospital stay, they were not significantly different if you do the scope early or late. So to end, some take-home messages. Pre-endoscopic stabilization is important. Always remember, ask history from the patient, examine the patient properly. If patient is in hypovolemic shock, adequately resuscitate them. If patients should be transfusion, you need to transfuse them. Patients are uremic, consider dialysis. If patients are high risk of aspiration, probably to electively intubate them early. Once all that is done, an early endoscopy, less than 24 hours, should be performed. So these are my references, and thank you for your attention.